Thank you, sir. Presenting before you, Professor Basu Gopal, consultant nephrologist, the Alfred Hospital and Association Professor at the Monash University, Melbourne, Australia. He's all the way from Australia and in Australia on online mode, of course. Over to Dr. Basu Gopal.
Sir, we are not able to hear you, sir. Sir, please kindly check your audio.
Good morning, everyone.
Yeah, now it's coming.
I would have loved to be there and meet a lot of you. Unfortunately, I'm not in a position at this point. So I'm going to give a small talk on kidney transplant in highly sensitized recipient. I would like to, before the talk, thank the organizers for inviting me and pay my tributes to Professor J.C.M. Shastri. I would like to share my screen now. Yeah, okay, great. Now, kidney transplant in a highly sensitized recipient. That's pretty much like what this man is doing. It's like climbing a cliff on a thin rope, and it is not a simple task. So I would try and discuss some aspects of it and some newer developments in this talk. Sensitization refers to formation of antibodies against HLA antigens, and sensitization happens due to various exposures. Pregnancy is one, blood transfusions is one, and organ transplants, either a previous kidney transplant or an organ transplant from any other organs like a liver or lung or a heart. And of course, occasionally you've got infections which can have molecular mimicry with HLA antigens, and all of these exposures prior to a transplantation or even prior to patient becoming a chronic kidney disease patient would result in formation of HLA antibodies, and that happens by the immune mechanism. The immune system, as you know, has got the antigen-presenting cells, which would have presented either the HLA antigens or a molecular mimicry antigen to the T cells, and result in activation of this T cell. The T cell would produce a variety of cells. They could differentiate into active CD8 T cells, which are effector cells, CD4 T cells, which help B cells, and also some degree of memory T cells. You've got the CD4 T cell helping the B cell at germinal centers of secondary lymphoid organs like lymph nodes, spleen, etc. And the B cell would then differentiate into plasma cell, which forms specific antibodies against the antigen that was initially presented. So that information is carried on and results in formation of antibodies that would act against this particular antigen. They also form the memory B cells, which would remain in lymphoid organs and then be called upon every time that a similar antigen or same antigen is represented. And these plasma cells would produce, as I said, antibodies. And presence of this antibodies against an HLA antigen is what is called as sensitization. Now, how does it impact what we do? And if the patient gets a kidney transplant, that results in antibody-mediated rejection as well as cell-mediated rejection. So you've got the CD8 T cells are either circulating or memory T cell expanding to form effector cells that destroy the tubules as well as the arterioles in the kidney, causing acute T cell mediated rejection. But even before this happens, for this to happen, it takes a few days. But even before this happens, the antibodies will effectively damage the kidney by causing an inflammatory response at the endothelium. So you've got both peritubular capillaritis as well as glomerulitis as the initial starting inflammatory points. It can go on to even cause significant thrombosis of the arterioles in the kidney, resulting in absolutely necrosis of the kidney, and what sometimes used to happen in on table and is called as hyperacute rejection. Much of this is what you already know. So how do you measure sensitization? Now, measurement is based on identifying anti-HLA antibodies. Now, previously we used cell-based assays, CDC cross-match, and then moved on to flow cytometry cross-match. These are still being widely used in most parts of the world, but the CDC cross-match is slowly going out of vogue because of the prominence and the utility of other technique, that is the Luminex-based solid phase assays. Now, the solid phase assays are available in India, but unfortunately they are very expensive and also, more importantly, quite confusing to use for many clinicians. And the labs give a report without there are very few labs which would engage in a conversation with the clinician and try to tease out what is going on. And often there's a report that is given in the clinician's hand and they're struggling to make sense of it and wondering how to proceed. Now, the problems also with solid phase assays is that there's not, although the method is standardized, the output and the results vary from place to place, and that is an issue. The advantage of the solid phase assay is it's highly sensitive, and it's also a disadvantage. While it picks up any and all sensitization, it can overcall sensitization and therefore result in some patients being subject to unnecessary treatments, whereas a CDC cross-match would be, if it's positive, it's a contraindication. You can't do a transplant if CDC is positive, but a solid phase assay, it just gives you an idea of the risk rather than absolute contraindication. So a lot of literature exists on trying to correlate between these methods. As I mentioned, CDC positivity means contraindication. Flow cytometry shows an increased risk, but low levels of cross-match positivity in flow cytometry. Most people wouldn't do transplants at that time, but if you do have a correlating CDC that is negative, you could use heightened immunosuppression and go ahead. Whereas single antigen bead assay, there are no absolute thresholds across the world, and it's center specific. Most people would use either 1,000 or 2,000 MFI as a positive cutoff, although the term cutoff or positive in itself is quite meaningless in this situation because of how variable it is. And there are various other, because of the artificial nature of the bead and how this is measured, there are various other parameters. Like, do you consider just a single MFI value, or do you take the combined MFI value of the donors, all the antibodies against a donor? Is it a class 1 that is more important, or class 2, or is it antigen specific? The same antibody could attack different antigens depending on what kind of epitopes are present. Do we worry about, if you have serial reports, do we worry about the peak serum, that is at the time when the MFI values are very high, or the current serum, that is when right now when you're going to do the transplant, the MFI values. And more importantly, what's coming back now is the importance of dilutions, because we understand that MFI is artificial and a lot of it is dependent on the bead and how many HLA antigens are coated onto the bead. So now labs are moving on to testing DSAs in dilutions of the serum to see in how many dilutions are you able to get rid of the positivity, and that being used as a titer. So while the world tries to kind of make sense of single antigen bead assay, it has come on to vogue, and it is fitted into this spectrum of risk stratification between what is a definite risk like CDC cross-match positivity and what is absolutely low risk where the solid phase or the single antigen bead is negative. So you do see that there is a wide range of variability here, and your patient might fit in anywhere in this pathway, and depending on that, the transplant would progress. I'd like to just give you an example of how the positive cutoffs can vary. For example, this is UCSF values, and you can see that HLA-A or B more than 2,000 is considered positive, whereas C has to be more than 6,000 to be positive, or more than 3,000 for a summed class 1. That means if they've got an A as well as a B, or two A antibodies, you add the MFIs together, and if it's more than 3,000, that's considered positive, and similarly a 5,000 for summed MFI. What we have is that the lab would give us a 2,000, anything more than 1,000 as positive, depending on mild, moderate, or high levels. But we have this in our minds when we interpret it, that is, if it is A or B in our labs in Australia, that more than 2,000 is considered positive, or a combined more than 3,000, a C more than 4,000. You might ask us how this came about, and these were done with using a lot of patients whose single antigen bead assays were available in a central laboratory, and they did flow cross matches along with those single antigen bead assays and correlated the cross match positivity to the single antigen bead MFI values and came up with these approximate cutoffs. And so that brings us to the point, if we really have to make sense of this assay and to use this assay further, it's really important to have a central laboratory, and or at least a group of central laboratories that would support a particular group of clinicians or clinician groups that can help coordinate and give meaningful information on this DSAs. Now, as mentioned, the DSA is only one part or one piece of the puzzle. You can say that there is a variable degree of risk in terms of DSA being positive to negative and in its interpretation. So if you've got someone who is day 0 DSA positive with CDC crossmatch positive, transplant is not possible. They require desensitization before transplant or to find another donor against whom they don't have donor-specific antibodies. If the day 0 DSA is positive with the flow but a negative CDC, that means there is DSA. It's got some activity, but it's not strong enough to stop the transplant. It's possible to do the transplant. You may not lose the graft to, there's a less risk of losing this graft to hyperacute rejection, but there's a very high risk of acute antibody-mediated rejection and accelerated chronic AMR. If the day 0 DSA is present with negative flow, that is a step lower, and then you can see how absence of day 0 DSA does not mean that everything is all right. There could be previous exposure and DSA, but currently it's not circulating, so there could be an evidence of memory. In this whole variety of risk, our patients, the highly sensitized patients, are a bit complex, and the word highly sensitized is taken from the context of deceased donor transplants, where you've got a patient and you're trying to match the patient to a deceased donor. And they would react with almost so many of those deceased donors in the cross match that they are hard to match. And that's what this test, panel reactive antibody, says. Panel reactive antibody tests how many patients, how many donors, out of the 100 donors that we have, how many would match, would not match with the recipient. So if the PRA is 98%, that means they would only match with the 2% of the recipients, whereas a PRA of 20% means that they've got about 80% of the population to match with. As such, it's hard enough to find a deceased donor for many of these patients, even with 0% PRA. Now, if you've got a PRA like this, it makes it really difficult. This PRA was developed when CDC or cell-based assays were present, but now we've moved on to single antigen bead assays, where instead of doing a PRA, we just look at a cutoff MFI value and then say beyond this MFI, whatever antigens are represented, they would be unacceptable for a transplant. So that gives us, based on an understanding of what the population HLA is, it gives us an idea of what is the probability of finding a transplant donor, and therefore what the calculated PRA is. So that's the difference between a measured PRA and a calculated PRA, because this is from the virtual single antigen bead assay. And as you can see here, this is the calculated PRA. And if you see, this is 75% or 95%, 99.99%. See, the probability of finding a donor is so low. It's 1 in 30,000 or 1 in 46,000 for these patients. That means if they were if they were matched with 46,000 patients, only one of them they would actually match with. So these patients in their lifetime would get about maybe 10 or 15 or 20 offers at best. They're not going to get anywhere near these numbers. So these are patients who may stay in the disease donor wait list and never find a donor, or very, very lucky if they found a matching donor by themselves. So highly sensitized. Therefore, the cutoff for highly sensitized starts at this particular value of 80% or 85%, depending on which side of the Atlantic Ocean you're on. And really, as you can see, these are patients who are going to be incredibly difficult to find a donor for in the deceased donor wait list. And not only that, having classified them based on the PRA, it's known that the highly sensitized patients and sensitized patients in general have longer waiting time on the wait list. They have higher rate of non-transplantation. While they wait in the wait list, they die before they get a kidney. If they have a transplant, they are at a higher risk of antibody-mediated rejection and poor graft survival. And currently in the Western world, at least 20 to 40% of the waitlisted candidates are highly sensitized. We are very good at transplanting those who are able to find a match, and those who are not able to find a match remain in the wait list, and they keep increasing in the numbers. Now, this is a problem where the deceased donor transplant is quite set up and active, but it's really a problem even in the living donor setting, where you've got the one single donor that the patient can have, especially in the absence of a deceased donor transplant program or a ready access to the deceased donor transplants. You find that that patient with that donor and with parameters that makes it very difficult to match is the problem of HLA incompatible transplantation, where there's a positive cross match, either a CDC or a flow, or a DSA at an MFI that is too high or above the threshold that we talked about. So what are the options for these patients? How would we transplant such a patient? So is there a kidney exchange program is the first question. Is there allocation schemes prioritizing sensitized recipients? Do these allocation schemes include acceptable mismatch program? These are the usual questions I would ask where I work before I decide for a patient to go undergo sensitization. Why is that? Why do I not jump in and start doing desensitization, even if the patient comes up with this living donor with whom they have an incompatibility? Because I'm always trying to find a compatible transplantation, as compatible transplants hands down win in terms of any competition. Whether it's less risk of rejection, less risk of graft loss, less need for immunosuppression, less risk of infections or malignancy, or even less patient deaths. So in terms of outcomes, it's always good to find a compatible transplant. And so societies like ours should really look to try and promulgate bodies that would govern programs such as this. And they don't necessarily have to be set up nationally. They could be set up even at local levels for ease of and several such programs have now are established in India as well, which is good to see. Now, what does the allocation scheme mean? You all know deceased donor allocation works by wait time. A lot of the time, the blood group and wait times are given the most importance across almost all places in the world. It depends on when you registered or when you got started on dialysis, or that you get given priority. But priority will world over is now moving towards prioritizing or moved towards prioritizing highly sensitized patients to be offered compatible organ on priority. In Australia, for example, we have Anybody who's got a PRA that is above 95% gets a priority of receiving an organ from a compatible donor. That means they may have just joined the wait list, or they may have been in there for 15 years. It doesn't matter. When there's a donor that is matched with them and it's compatible, they'd be given priority to take that kidney compared to everybody else who may have been waiting on the wait list for longer than them. So it's not just a wait time based, it's actually based on how sensitized they are and the fact that they would otherwise not find this particular donor in their lifetime. Priority has to be set at different levels of sensitization, and it has been very clearly shown to increase the transplantation rates. I mean, this is a busy figure, but if you look at the last set, that is those a graph of the years of wait list on the wait list and incidence of transplant in people who have 99.9% PRA. You can see this is before these two are before an allocation scheme was changed to prioritize sensitized patients, and this is after allocation scheme is changed to prioritize sensitization. As you can see that the percentage of transplants that have occurred in these patients have literally doubled in this situation. Otherwise, these patients would never find a donor, but it hasn't changed the transplants that happen in the overall population. It remains, if at all, slightly better or the same. So the overall number of transplants doesn't change, but the transplant organ gets allocated more effectively and efficiently. And when you have such a program, it's really important to define what are the acceptable mismatches. Now, this is again very important in a deceased donor setting where you have information about what is the HLA antigens, what are the antibodies they have, and how do I find a match for this recipient. And you may have a lot of antibodies in this panel. For example, if you look at the single antigen BDA, you've got lots of antibodies that are above an MFI cutoff. Okay, you might want to say that these two antigens you are willing to accept, provided that you're able to do something to get them below the threshold here. For example, some kind of desensitization at that point. Or you might test those antibodies in a CDC cross-match and then find that those antibodies are not really causing a positive reaction. And therefore, even though they are positive based on MFI, because a CDC or a flow cross-match is negative, you are hedging your bets and trying to say, maybe I will accept a donor with that antigen. That is called an acceptable mismatch program. What it has done is well established in Europe, and what it has done is to increase the number of transplants that acceptable mismatch program, especially for those with a more than 85% PRA. So you can see the red, orange, and the green lines are transplant rates and graft survival and death sensor graft survival of patients who had PRA of 0 to 5%, 6 to 85%, or more than 85% before the acceptable mismatch program. Whereas the acceptable mismatch program is only for the highly sensitized, that's above 85%. So you can see that their transplant rate has gone from the red line to the blue line, and their graft survival and patient survival has improved as well. So it's these are the two important deceased donor-based strategies that we do to try and give them a compatible transplant. Now, the third and the more important and more widely used and more famous one is the kidney exchange program. This is again well established, I think, in some areas in India, and is something that is very useful if groups of people can collaborate. The concept is not new. I mean, everyone knows about paired kidney exchange. You've got incompatible donors and recipients. The donor A donates to recipient A, and donor B donates to recipient B. You can start off with a two-way chain. You could have three-way or four-way chains, which are called, which start off with one pair and then go on to the next and the next. Important that both donor nephrectomies happen at the same time and the transplant all happens on the same day, so that no one can bail out and be lost in this chain. There's also a new way of doing this, and which is now present in most of the places, including Australia. That is a you get either an altruistic donor who's just willing to give a kidney not to a specific person but just to anyone, and then their kidney is then put into a pair kidney exchange program where it starts off a chain of transplants. So you got that kidney goes to recipient one, and then donor one to recipient two, donor two to recipient three, and it goes on to a chain. And at the end, either there's a chain stops, pauses for some time, and then continues, or the last donor is allowed to donate to someone in the wait list, deceased donor wait list. So this is called a domino transplant. And there are, 7, 6, 5, 10, 14 pairs that are happen in such ways. And these programs really need a lot of management and logistics to be organized, and inter-departmental, inter-unit communications and inter-hospital communication to be set up. And well-run programs have usually, sorry, that's a less than symbol. Well-run programs usually have a less than 2% of chains breaking. But this has also certainly increased the number of compatible transplants and increased the options not only for ABO incompatible pairs but also HLA incompatible pairs, and helped improve outcomes. But what is important is that someone who's got like a PRA more than 80 or 95%, while they may be able to find a donor in the pair, it's often they're waiting long enough as well here as well, and that the only advantage is this is a living donor transplant, so you get slightly better control of the desensitization if you're trying to accept some acceptable mismatches, are able to do that along with this. If the patient cannot fit in with any of these programs, then that is when you would consider desensitization. And desensitization can happen in both in a deceased donor context as well as a living donor context. So you've got a direct transplant with enhanced immunosuppression for an acceptable mismatch. There's a living donor, and there's no kidney pair exchange program. And it's now understood that the patients who would benefit from desensitization, as in, there are patients who would rather do well on dialysis than be desensitized and result in an infection and die. So there are groups of patients who would benefit because they would have some survival advantage, especially the ones who have a PRA more than 99% or a CPRA more than 98% with more than 5 years of wait time. What are the ways in which you desensitize? Now, I want you to recollect the immune pathway, and we attack this with several approaches. The first one being intravenous immunoglobulin, which actually has a multitude of effect on a variety of these cell mechanisms. Then plasma exchange and immune absorption try and address the antibody directly. And then you've got other agents that affect the other cells, like T cell lytic agents, B cell agents, proteasome inhibitors, complements, IL-6. We'll go through some of these strategies now. Now, intravenous immunoglobulin is widely used in desensitization. I don't think there's any program that usually does not use IVIG. I think most people use that. It's a broad spectrum of mechanisms of action. There are lots of mechanisms of action, means that no one knows exactly how it works, but it works. It works possibly by neutralizing the HLA antibodies by binding to these idiotypes and cancelling off their effect, or by inhibiting complement activation. It also kind of blocks the Fc receptors in the immune cells, so the immune cells are not activated. It prevents rebound of DSA by negative feedback and signal of abundant circulating immunoglobulins, and therefore, the B cells or the plasma cells think that there's lots of immunoglobulins, and they're not switched off. They're not switched on to produce too many of the native ones. And there's a multitude of other effects on other cells and immune mechanisms. Usual starting doses used to be 2 grams per kilogram, but current doses depend on whether you're using it along with plasma exchange or additional to plasma exchange. The doses vary, and they're usually given in divided doses to avoid adverse events. Plasmapheresis with immunoglobulin is the current standard practice. That extracorporeal removal of antibody has been studied in the desensitization since the 1990s. It has it has resulted in more transplants and less antibody-mediated rejection. So in this study, you can see that IVIG resulted in IVIG alone resulted in less transplants, whereas plasma exchange with IVIG resulted in nearly more than 2 times the number of transplants and half the number of patients suffering antibody-mediated rejection. Based on the plasmapheresis IVIG protocol, if you did desensitization, that is better than remaining on dialysis for most patients who have PRA that is above 50%. And this study involved plasmapheresis IVIG and tacrolimus, which is equivalent of besiliximab. And you see that PRA in this group mean PRA was about 80%. So this is true even for those who have a PRA of about 80% that is highly sensitized. If you did plasma exchange, the number of sessions you need to do depends on the MFI of the antibody you're trying to reduce. So you started off with something that is 1,000 or 2,000 MFI. It's very easy to get rid of the antibody completely. Whereas if you start off with, let's say, MFI of 10,000, then you'd only be able to get 60% of the MFI reduced. You cannot reduce the MFI any further than 60%. So you really have to pick which patients you're going to desensitize depending on how high the MFI you're trying to cross. And often we say, more than 10,000 MFI means it is not easy to desensitize. If it's more than 20,000 MFI, you basically cannot do it. So there's increasing difficulty of desensitization that is possible with increasing titers of antibodies or MFI values. And you can see that if the MFI is less than 3,000, you're able to get rid of most of these antibodies, whereas if this MFI is more than 12,000, despite many sessions of plasmapheresis, you're not able to remove these antibodies successfully. So while plasmapheresis does remove antibodies, and you can use IVIG to counter its effect, you really need to address the source of the antibodies, which is the B cells. The other way to do antibody removal is immunoadsorption. It allows for larger plasma volume, so you can treat up to 4 times the plasma volume. You need about 3 to 5 sessions pre and post transplant in these situations, and you could use a membrane filter to kind of help clearance with IgM and C1q. But the membrane filter also depletes hemostatic factors, so you need to worry about that as well. Now, there's not many large studies looking at immunoadsorption with plasma exchange, and immunoadsorption is quite costly. Not everyone has access to it. The next kid in the block is rituximab. It is, of course, not a kid in the block, very seasoned player at this point. Everyone knows and has used rituximab at least once in their lifetime, and if you're a nephrologist, and for various reasons. So you used in combination with plasma exchange and IVIG to reduce PRA. It allows for about 70% of the transplant when used. You can see how the T cell flow cytometric and median channel shifts nicely down in the study, and how PRA reduces from about 80% to 70%. So you're increasing the chance of crossing some of those antibodies, but not all of them. And a reasonable patient survival and graft survival. So most of what we do tries to kind of modestly reduce the PRA to allow for some of the transplants to happen. As you can see, if you use rituximab, the chance of rebound of antibody is less compared to not using rituximab. So it's become standard practice to use rituximab in most of the desensitization protocols. Not only does the antibodies remain low, the risk of antibody-mediated rejection, the risk of rebound of PSA is much less with rituximab compared to without rituximab. So it's commonly used. Unfortunately, rituximab also has a time limit in terms of how it acts, and it's not as effective or long sustained treatment. And because it is chimeric, there is also resistance in anti-rituximab antibodies that develop, which reduce its efficacy if you need to continue to use it. So there are other more humanized versions that are being studied. Now, this is an CD20 antibody that's slightly different. It's a type 2 kind of antibody. It is more efficient at depleting B cells for longer. And the phase 1 trial for obinutuzumab for desensitization is published in, I think, in 2019. It showed that there is significant reduction of B cells, a proportion of the patients did drop their antibody MFI values, as you can see in the green lines here compared to the orange lines. And however, it didn't really shift the PRA much, and except for a few patients who we were able to do transplants, the others remained on, with the same PRA. So it was somewhat effective in reducing B cells, a little bit of antibody, but didn't really clinically change much. And this was obinutuzumab as an agent, single agent. There are other B cell targets now. We have belimumab and atacicept, which are being looked in animal model studies. All of them, when used individually, are not effective, but the question is that the right way to use them? Of course, targeting plasma cell was always looked at as an important component. Botusumab was used enthusiastically and studied when it came up. It resulted in reversible proteasome inhibition and plasma cell destruction, but it really didn't help in desensitization. It did not change the PRA. MFI reduction, if at all, was modest, and a lot of people had side effects. So it never kind of picked up, except in very significant circumstances where desperation took the best of us. Carfilzomib is a newer proteasome inhibitor in nephrology, newer only in nephrology. It's been there for some time in hematology for myeloma treatment. It's irreversible and sustained activity thought then it could be used in desensitization. It resulted in reduction of the immunodominant DSA. When you say immunodominant, that means that's the DSA that's very high and is actually causing a problem in terms of the matching. But there was significant rebound after discontinuation, even though it is irreversible. There was a lot of this rebound. So we understood that, and a similar thing was observed with daratumumab in animal studies. There was significant rebound, and also daratumumab additionally kind of destroyed the regulatory cells, the T and B regulatory cells. So you got a lot of TCMR, T cell mediated rejection. So we understood that targeting just one cell or one particular aspect of a cell is unlikely to yield significant results. That brings us to IL-6. IL-6 drives B cell activation and differentiation to a naive B cell as well as to plasma cell. And IL-6 is produced from a plasmablast. They also inhibit FOXP3 cell and therefore reduce tolerance. And they also have impact on the endothelium. And endothelium starts secreting IL-6 when antibody binds to it, results in further inflammation. So IL-6 is now a hot target for everything transplant. A humanized monoclonal antibody tocilizumab came into a lot of fame because of COVID-19, and a lot of people got to use it and are more versed with it at this point. Tocilizumab alone causes significant MFI reduction, but it has not been shown to be clinically significant alone, but it's proven to be safe. And but when discontinued, tocilizumab is a receptor blocker, so it stops the IL-6 from binding to the receptor. But when stopped, the IL-6 kind of builds up, accumulates, and it causes a rebound phenomenon. So we use there's a newer IL-6 antibody called the clazakizumab, which is being used in desensitization protocol, and this is a very interesting protocol which looks at using clazakizumab monthly before transplant for a few months, and then continue it post-transplant at doses at 25 milligrams, and use the usual plasma exchange, IVIG, and in this case they used Campeth, but if you're using rituximab with basiliximab or hemoglobin, you probably get similar results. And it allowed for 18 out of 20 patients who had highly sensitized to undergo transplantation. And you can see a sustained reduction in the DSA. So this is pre-desensitization. This is at transplant. Post-transplant, it's remaining low. And there's also an increase in B and T regulatory cells, indicating there's some degree of tolerance that might develop. And the antibody-mediated rejection rates in this group was only 17%. So this is a hot molecule that
Dr.
is currently
Dr.
being
Basu,
considered for the next protocols. And you can see lots of studies. I've got only a minute and I'll finish.
1 minute, yes.
Imlifidase came with a lot of interest because it destroyed the antibodies, but it was of strep origin and it resulted in antibody formation in itself, uh, making it a self-fulfilling prophecy, and wasn't very useful because in 3 to 7 days time there was rebound of antibodies and antibody-mediated rejection at best. It could be used as a replacement for plasma exchange in the middle of the night when you get a deceased donor with whom there's a lot of antibodies. Complement inhibitors by themselves have not been very useful, and they're useful as adjuncts, especially to prevent antibody-mediated rejection. So we have all these strategies that have come up in terms of desensitization, and the best way to use them is how we use our
Yes.
spices in our kitchen, mix them up. And depending on what we're trying to achieve, what has been the history of the patient, what is the sensitization level, and which antibody are we trying to cross. So to conclude, antibody-mediated rejection limits graft and patient survival in highly sensitized patients. The best options remain compatible transplant if you can able to provide either an organ allocation priority, pair kidney exchange, and acceptable mismatch program. When that's not very helpful, especially in very highly sensitized recipients, and you've got a donor or you're looking for a least worst option, then you go for desensitization, and the current standard still remains plasma exchange, IVIG with hemoglobin or rituximab or rituximab. IL-6 targets therapy looks a bit promising. The other agents are at best adjuncts. And as most importantly, what I've not touched about is the lack of the impact of all these molecules in a subcontinent, especially when there's infection and survival and malignancies are likely to claim lives, is really important to keep in mind before jumping in to use any of these strategies. Thank you very much for the opportunity, and I'm happy to hang around till the end for
Thank you, Dr. Basu. Although we are taking up questions for others later, maybe a question or two for you. As a starter, your take on anti-MICA antibodies.
So, I mean, I didn't specifically talk about non-HLA antibodies because that is again a large number of studies are looking into the importance, significance of non-HLA antibodies. The most prominent of the lot is the angiotensin 1 receptor antibody, and of course, minor histocompatibility antigens are also present. So I don't think there's still enough evidence to say pre-transplant testing for these antigens and antibodies is necessary unless you've had a patient who's lost a kidney transplant and you don't know if there was no DSA and you're trying to find out what caused the previous graft loss, and then you try and prevent that from going on to the next happening in the next transplant. So I would think that at this point we're still trying to figure out the HLA antibodies.
Thank you, Basu. That was a wonderful lecture again. And your final point is very well taken. In spite of all these developments, whether all these can be translated into clinical practice in this particular part of the country where the infections are ruling the roost. Thank you so much.